Okay, guys, here we are. My presentation would be on the proposed study for the effect of linear periodization on patients with heart failure in phase 2 cardiac rehabilitation. So, just a little background on it. Phase 2 or cardiac rehabilitation itself is an insurance-based exercise program. It's often used for individuals who are treating a heart-related condition or are recovering from a heart-related incident. So think of any time somebody has a heart attack or they have open heart surgery or they have a valve replaced, anything like that would qualify them for this program. And most, if not all, use the AACVPR guidelines for exercise prescription, which are taken from the American College of Sports Medicine. Now, research in this field is predominantly focused on patients with coronary artery disease. There's also been some work done that looked at periodization used in phases 1 and 3. Phase 1 is mostly is inpatient, so think of while they're still in the hospital. Phase 3 is maintenance, so whenever they graduate from their phase 2 program and they're not bound to the program itself. Unfortunately, that means heart failure and valve disease is not as extensively researched, though that doesn't mean it's not researched enough or researched as is. It is just not as heavily researched as CAD. So my big thought with this was, what if we started to incorporate more NSCA-based guidelines and some thoughts and procedures from that side of exercise science into this? So for this study, the participants must be diagnosed with heart failure with an ejection fraction. So think of the amount of blood that the heart's pumping. If that total percentage from that left ventricle is less than 35%, and they don't have an LVAD. So that's just a left ventricular assist device. So if their heart isn't strong enough to pump blood out, they need an LVAD to help it pump blood out to the body. And no major hospitalizations or procedures within 6 weeks prior to the start of the study. And these have been taken straight from the Medicare guidelines for what they would cover for heart failure and cardiac rehab, minus the bit about the LVAD. I added that. So the instruments used are the 6-minute walk test. It's a functional test used to kind of gauge how much work the individual can do. The rate your plate, which has been correlated to highly correlated between body fat percentage as well as between their dietary habits. The Dartmouth COOP is kind of an all-encompassing survey that covers areas such as physical activity, emotional status, pain, all sorts of factors that kind of go into a person's daily life. Then there's the DAISY, the Duke Activity Status Index, and that is just a physical sort of activity index of what patients have been doing within the past couple of weeks. So think of things like moderate intensity things like walking uphill, shoveling, raking, if they're walking slow, if they're jogging, or if they're having sexual relations. Those are all kind of questions that are on that study. Then there's the Patient Health Questionnaire 9, that's the PHQ-9. That is a mental health survey that's a screener for depression. So for the procedures for this study would be simple pre-test, post-test. So we pre-test with the surveys and the 6-minute walk. We break them into their groups, the linear and non-linear periodized groups. They're given 16 weeks to complete 36 visits. Standard cardiac rehab phase 2 is you get 36 visits and you have a year to complete those from when you start. So if you did 3 times a week every single time, that's 12 weeks. I gave a little extra time because realistically, people are going to be missing appointments. It happens. It's a part of life. And then, like I said, follow up with the post-test with the same procedure, surveys and 6-minute walk. So when we get into sort of actually breaking them down into their groups, we have the linearly periodized, and then this is the macrocycle duration here. You see the weeks 1 through 4, 5 through 8, 9 through 12. Then the macrocycle focus, whether it be moderate intensity continuous plus resistance training, high intensity interval training plus resistance training, or you get over into the nonlinear. So I use more of a undulating procedure for that one. So weeks 1 through 4 are the same for both groups actually. They just get 30 minutes of moderate intensity continuous training to build up their aerobic base, and then from week 5 on is where they get separated. So in that NLP group, we see weeks 5 through 12. Monday is a high day, high intensity, and we use an RPE scale in this. So they'd be exercising at an RPE rating of 14. Medium days, that's Wednesdays, they bring it down to an RPE of 14. Low intensity days on Fridays, where they would do an RPE of 11. And Fridays in both groups are lowered intensity, so think anywhere from 60 to 75% of what the previous sessions from that week were, and that's all from the principles of periodization to prevent overtraining and allow for maximum adaptation from the work. Once we get the results, we would use SPSS 27 to analyze the data, pair t-test to analyze data within the group. So you have that LP group. I want to see what difference, if any, there was between the pre-test and post-test, and then I would use a one-way ANOVA to analyze the data between the groups. So then I could see, if I'm comparing the LP group to the NLP group, how big of a difference is there between their post-test data as well as their pre-test data. So all in all, if this were to be carried out, the practical applications it could be kind of brought out would be if clinicians who have an exercise background, another method of prescribing exercise so they aren't necessarily tied down to the ACSM method. And it can also lower the number of overuse injuries that we see a lot of in the older populations. They're largely with this population, they're inactive. So if we throw a lot of things at them, they're more likely to overdo it, get carried away, and get hurt. So using these areas of planned rest can really lower that risk, which would then increase their exercise adherence in the long term because they're not injured. They don't have to take time off to get treated for anything. And this would build upon the work of Boyden et al. In 2020, who show that periodization can be very beneficial for patients with coronary artery disease. And then this also further kind of connects the two sides of exercise science, whether it be clinical and performance-based, just to see and to use principles that are normally only found in the performance-based, and to give them a chance to shine in the clinical side of things. Limitations with this would be likely a small sample size. Heart failure alone is a very rare kind of referral, diagnosis for cardiac rehab. Normally, it's people will have a heart attack, they get stented, they get bypassed, whatever it is, but they also have heart failure. It's very hard to see a patient who just has heart failure get admitted. And another limitation of this study, looking back at it, was there was no control group. And that in part ties back to the small sample size, because if there's limited amount of people, it's hard to divvy them up equally into 3 groups to really examine. So looking forward, and something if I were to carry through with this was that I'd probably go with something more like valve disease, because that number, you're more likely to have more patients with a valve disease. So whether it's a aortic valve replacement or a transaortic valve replacement, mitral valve replacement, those are more common than just heart failure. So I think a study looking at the effects of periodization of that population would be very interesting to see. And then another one would be, could the method of exercise prescription influence program adherence or exercise adherence at all? Would it make exercise more enjoyable for this population, knowing that they have a little bit of variety kind of sprinkled throughout their program? Finally, with some conclusions, like I'd mentioned earlier with the applications, is that this could give clinicians a different way to do their job. Now, cardiac rehab is a very diverse field. It's often staffed by nurses, occupational therapists, physical therapists, respiratory therapists, as well as physiologists or specialists. So those with an exercise background can really use this for their patients in a way that maybe not other rehabs could, and it can really benefit their patients. And as well as to add just a little bit of work to a population that often doesn't necessarily get the shine that coronary artery disease does. And then have some references, and that's it.